Hello, my name is Anne Gagliardi. I'm a family doctor and I work at the National Center for Primary Care at Morehouse School of Medicine. I'm really honored to be here on behalf of my team to present this work that we did together as a NAPCRG distinguished paper. Thank you so much for having us. So today I will be speaking with you about our study that looked at the impact of historic concentrations of enslaved persons in U.S. counties on current day mortality rates and social determinants of health. And as I said, I'm here on behalf of our team at the National Center for Primary Care. I have no conflicts of interest. My goal today is to tell you about a county measure of historic structural racism that we use to examine the impact of this measure on contemporary mortality, poverty, income inequality, and educational attainment in U.S. counties. A brief geographic introduction for those of you who do not know where Morehouse School of Medicine is. We are located in Atlanta, Georgia. Morehouse School of Medicine is one of the 4 historically Black medical schools in the country. And our mission is to lead and create the advancement of health equity. We are devoted to producing a healthcare workforce that is representative of the population. And there you can see Dr. Valerie Montgomery Rice, our president, with one of our incoming medical school classes. The National Center for Primary Care is housed at Morehouse School of Medicine, and it is a congressionally designated center that's focused on strengthening the primary care system through education, research, and training to improve health outcomes and advance health equity. The center was started by Dr. David Satcher. As a personal reflection, I want to note that it is really my privilege to serve as a clinician scientist at a historically Black medical school whose whole reason for being is to advance health equity and build a representative workforce. And I truly believe it is all of our job to work to advance race equity. But I also acknowledge as a white woman that I strive to do this work with both humility and in partnership. Slavery is a root cause of institutional racism within the United States, and its effects persist as racist policies. I think place-based measures of historic racism are particularly difficult if we think about places as containers for people. But we know that places are not simply containers for people, but places live in relationship with populations and influence each other over time. And as anyone who has ever looked at any disease map of the United States knows, the southeastern US, where slavery was endemic, has worse health outcomes compared to the US as a whole. Place-based measures of historic and contemporary structural racism have been associated with poor health outcomes in several studies. The measure that we look at here, which is a historic place-based measure of structural racism that accounts for the concentration of enslaved people in a county, has been examined before in relationship to differences in decline in heart disease mortality in the Southeast among Blacks and whites. This is in a paper by Michael Kramer and colleagues across the way in Atlanta at Emory. This measure has also been looked at in relationship to contemporary violence, income inequality among Blacks and whites, and as well as among looked at in relationship to violence. However, this measure has not been looked at in relationship to broad population health outcomes. Our goal in this study was to examine the association between the concentration of enslaved people in a county in 1860 on contemporary population health outcomes and social determinants of health. in 2010. We hypothesized that the proportion of enslaved people in a county in 1860 would be associated with poorer contemporary measures of health and social determinants of health in U.S. counties. So we used publicly available data for this analysis. We got data from the 1860 census from IPUMS that provided the number of enslaved people and the county total population, overlaid on contemporary county boundaries. Outcome variables were obtained from the CDC compressed mortality file, where we looked at 2010 county-level age-adjusted all-cause mortality, and data from the decennial census that included the Gini coefficient, which is a measure of income inequality that ranges from 0 to 1, with 0 being perfect equality and 1 being the least equality. We also looked at proportion of the county population living in poverty in 2010 and proportion of the county population with less than a high school diploma. I'm also going to tell you about some analyses we did looking at this measure in relationship to COVID-19 disease burden. The inclusion criteria for the study was all counties with population data in the 1860 census that had complete data for the dependent variables in our models. So we conducted simple linear regression models looking at the proportion of enslaved persons in a county in 1860 as a continuous measure in relationship to the age-adjusted all-cause of mortality rate, the proportion of people without a high school diploma, the proportion of people living under the federal poverty line, and the Gini coefficient in U.S. counties. We also produced county maps using proportions of all measures that we studied so we could compare the spatial patterns of these measures.
Good.
There were 2,033 counties included in our study, and here we just present the description of the study sample. And so we look at quartiles of counties, counties that had 0% enslaved people to greater than 40% enslaved people. We can see that the counties with the highest proportions of enslaved people had lower educational attainment overall and for Black people, as well as higher levels of poverty,
Are you watching yourself?
higher mortality rates, and worse income inequality.
Mm-hmm.
So in addition to these descriptive statistics, we also conducted regression models that looked at the association between the proportion of enslaved people in a county in 1860 and our 4 outcome measures. And as you can see,
You sounded so professional.
all 4 of these outcome measures, all-cause mortality rate, proportion of the population without a high school diploma, proportion living in poverty, and income inequality, were all positively and significantly associated with the proportion of enslaved people in a county in 1860.
Gabe said he wants to take a tubby first.
Okay.
These are the maps of 2 of the main measures. The map on your left is a map of the proportion of enslaved people in a county in 1860, with red representing higher proportions of enslaved people in a county. And the map on the right is the 2010 all-cause mortality rates in U.S. counties. And the areas in red have the highest mortality rates. You can see that the spatial patterns of these 2 maps, these 2 measures, are very similar. So we found that this measure of proportion of enslaved people in a county was associated with higher mortality, higher poverty, lower educational attainment, and more pronounced income inequality in U.S. counties. And we noted that the geographic patterns of the proportion of enslaved people and the mortality rates were spatially similar. The patterns for the other measures were also similar, but in the interest of time, I'm not presenting those maps today. So despite migration of descendants of enslaved people across the country, these impact on outcomes still remains. we still note that higher mortality rates and worse social determinant of health outcomes are highly clustered in the South. The institution of slavery has had lasting and continued impact on the policies, institutions, and people living in the South, and continues to reinforce poor outcomes. We were intentional about looking at outcomes among all people living in a place because we wanted to show that the impacts of these policies are actually detrimental to the health of all people, not only racial and ethnic minorities. A recent study by Citigroup estimated the impact of race disparities on the US economy, and they found that over the last 20 years, the fact that we have not addressed racial gaps between Blacks and whites has cost the US economy approximately $16 trillion. The reasons for this cost include many of the things that we studied in this simple analysis: income, education, health, and certainly wealth as well. The authors of the study, who are C-suite level folks at Citigroup, noted that if we were able to close racial gaps, we would be able to add approximately $5 trillion of additional GDP over the next 5 years. And that this would not only be impactful for the US economy, but also be impactful for global growth. Some of the limitations of this study include a lack of spatial modeling that we could potentially address in the future by assessing and adjusting for spatial autocorrelation of the model residuals or employing geographically weighted regression. Also, some other research groups have stratified analyses by regions of the South that were more or less dependent on slavery as part of their economy. We could also consider selecting intervening covariates, including race-specific poverty, incidents of racial violence, or race differences in educational attainment. As I mentioned before, we also looked at this measure of historic structural racism and COVID-19 disease burden in US counties. For case rates in US counties, we conducted linear regression models and log transformed the outcome variable as it was skewed. We presented the exponentiated beta coefficients here, but did note a positive association between the proportion of enslaved people in a county and the COVID-19 case rate per population. And we conducted a negative binomial regression model offset for population, looking at this as a predictor of the deaths per population in US counties as of late September, and also found a positive and significant association. These are the maps that show, again, on the left, the proportion of enslaved people in a county alongside the COVID-19 case and death rates for late September. And you can see these patterns are visually similar. So we present a place-based historic measure of structural racism as being positively associated with modern-day mortality rates and social determinants of health in US counties. Certainly, it's important to do further work to understand how this measure might be utilized to target and develop interventions to change racist policies and alleviate the impacts of structural inequity. I am not suggesting that this is work we do alone as primary care researchers, but I think that we need to collaborate broadly with movements and advocacy efforts to bring about broad structural change. I think we have a path forward in the example of the South African Truth and Reconciliation Commission. I think that although This is a measure of structural racism, and broad policy change is certainly needed to support change. This does not exempt us from doing anti-racist work at individual levels, within our research teams, within our institutions, and as a community of primary care researchers. And so I encourage us to engage in that work so we can be agents of change to support that broad structural change. This is our wonderful team who collaborated on this project together. I want to specifically point out Amaya Walton, who is our summer research student, who actually presented these findings in our summer research symposium before they have been presented today. I will leave my references for you to have if you need, and I am certainly happy to answer any questions. Thank you so much.
So thank you so much, Dr. Gagliati. That's such an excellent presentation. We really appreciated hearing your presentation. And I do have some questions for you. And please, audience, please do continue to type in those questions into the question and answer section, and we'll be sure to get them to the presenter. So Dr. Gagliati, I was very curious about how you chose the social determinants that you looked at.
Thanks, Dr. Tapp. Yes, we chose the social determinants based on our previous work and based on the previous work that has been done with this particular measure, which has been shown to influence educational outcomes, outcomes related to income, outcomes related to inequality. And then we also wanted to look at the impact on health using all-cause age-adjusted mortality as an addition to the literature.
Mm-hmm. And did you prioritize how you chose those measures, or was that?
We did not. This was an exploratory study, and we picked the measures that had been established in the literature as a starting point.
That's great. And what do we know about counties with high 1860 enslaved populations, but now they have better mortality and education?
I think that this would be a wonderful thing to explore as a next step to this work. We have not looked at that, but our group is really devoted to understanding resilience, and so it would be, I think, a natural next step to characterize those places that had high proportions of enslaved people, but paradoxically low rates of mortality or better social determinants of health.
Yes, absolutely. So perhaps a qualitative approach going into those regions and chatting about these results and trying to understand what's changed. Yeah.
That would be great. I think these maps really lend themselves to community engagement and tell a really interesting story. So that would be a great tool to do that work.
Mm-hmm. Okay. And just a quick question. What's the denominator for the 1860 proportion of enslaved people?
Yes, it's the total population in the county in 1860.
Right. And then more thought-provokingly, we've got a couple of great questions here. What can we do to advocate for policy change to address the impact of institutional racism?
Well, I think we can start by prioritizing micro-level equity in our own spaces. Our group has put forth a theoretical framework called PEDAL on how to integrate health equity into the learning health system. And so I think we can start at home by prioritizing equity in our research pipeline, in our workforce pipeline, and in our health systems. But I think we have a powerful voice as healers and as trusted community partners to partner with other organizations who are working in those broader advocacy spaces. And I hope that we can continue to effectively do that, because I think there are some good examples of how that is happening.
Absolutely. And definitely these are profound results. And the next question also asks about your advocacy plan, and what do you think ours should be?
That's a great question. So I don't presume to be able to tell NAPCRG what to do as far as its own advocacy plan. But I think that we're hoping to actually share these results via advocacy briefs via our health policy division, and hoping that we can translate these results into some messages for policymakers, but also hope to engage community members around digging into the meaning of these results as well. So this is very early work, and we're looking forward to continuing to explore it and make meaning of it with community members and other leaders.
Yeah, that just seems like the logical next step, and to have that participatory component as well will be a source of great, rich materials for you to understand, where best to go with this really fascinating work. Wonderful. Well, thank you so much. And coming up, we'll have our next speaker, Dr. Bev Green. Thank you.